Hello, everybody. My name's Alastair McLellan. I'm editor of the Health Service Journal. Welcome to our webinar on organising care around patients, stories from the front line of the NHS, which is the title of a book written by Naomi Chambers, who's Professor of Healthcare Management at Alliance MBS, Jeremy Taylor, Director for Public Voice at the National Institute for Health Research. The issue of patient-centeredness is one that has been a common theme throughout the 20-odd years that I have been involved in health policy. It is a goal that every government, every public agency, every NHS hospital, every representative body will say they're trying to achieve, to give patients a greater sense of ownership of their care. And sometimes they even really mean it. Yet it is a debate which continues to run and to which there is, I would say, growing levels of dissatisfaction that it is that patient-centeredness is not being achieved. I think that is partly as a result of the world we live in today, where we expect a greater level of personalisation services that we receive. Anyway, I've known Naomi and Jeremy both for a very long time, and they've been very. I know that they have done a lot of thinking, a lot of work on this. On this subject. So I'm going to hand over to them in a moment to talk about the book, why they put it together, what they think its message is. Then we're very lucky to have three eminent panelists with us: Kath Checkland, Professor of Health and Professor of Health Policy, Dr. Habib Naqvi, Director of the NHS Race and Health Observatory, and Imelda, Redmond, International Director of Health Watch. After we've heard from Naomi and Jeremy, I'm going to ask for their reflections, and then I may have some questions but I'm going to encourage you to ask as many questions as possible. I think we've got an hour and a half until 2 o'clock, which is a good chunky piece of time. So Naomi, are you starting?
Yes, I am. Thank you, Alastair. And I just want to say thank you to Alastair for agreeing to chair this today. We need to congratulate Alastair and his team. They've just been winners in the Association of Online Publishers Awards for Editor of the Year and Team of the Year, Alastair. So congratulations on that. I will, in my 5 minutes or so, I want to give a flavour of the book, its origins, and also what Jeremy and I have learned along the way, and then I'll be handing over to Jeremy. But first I want to say thank you to our editor who is joining us today, Tom Dark, who's been very patient and with great humour along the way, and the production team at Manchester University Press. Also to our two informal readers, Alina Laurie and John Hitchins. I think Alina is joining us today, and also above all our colleague Elaine Clark, who volunteered to bring some of the patient stories to life so beautifully in an audio version. So I just want to start with saying that I've been keen for a while on the power of storytelling, and I'm still obsessed after more than 40 years with how to make the NHS better for patients and for staff. Recently, nothing to do with healthcare at all, I've been influenced by the work of two journalist writers who might not be known to you very well, one of whom is Svetlana Alexievich, who won the Nobel Prize for Literature, in fact, from Belarus, and Wendy Perlman from the US. And they use, as kind of journalist writers, they use montages of unfiltered interviews to immerse us politically in the tragedies of Chernobyl, the Soviet war in Afghanistan and Syria, respectively. So Jeremy and I conceived the idea for a book which would curate a series of compelling narratives of patient experiences from birth to death, very much following in the steps of these writers. The challenge of organising care around patients, of course, is not instantly fixable, as Alastair has pointed out in his 20 years involvement in this area. If it had been, it would have been. As a consequence, however, of our immersion in these stories, we've come up with what we think are 5 principles, which, if followed, we think could collectively offer a better way forward. And actually, Becky, if we could have that first slide now, that would be brilliant. Thank you so much. I need to say this is a work in progress in terms of visualizing the framework, but here we go for now. We conceive it as 5 principles, which together produce what we would consider to be drawing from the stories, patient-centered care. And those are the 5, and you will be very familiar with kindness and compassion, but without attentiveness, empowerment, professional competence, and above all, organizational competence, those pillars can be, if one of those or 2 of those are missing, then the edifice becomes extremely fragile, which we're very conscious of. So could we have the next slide, Becky? Thank you. So the next slide demonstrates in a different way how interconnected organisation for patient-centred care is, according to the framework that we suggest coming out of the stories. So without all of those together, you cannot achieve that patient-centred care. I guess what we're saying here is this is a call to action for the NHS. Bruised and battered as it is, well, we're not post, but because of COVID-19, but also because of the stresses and strains before COVID-19 struck, bruised and battered as it is, still a call to action about thinking and acting in a different way to get to a better place altogether. I'm going to hand over to Jeremy now, who's going to be talking in a bit more detail about the range of patient and care experience that is covered in this book. I should also say that thanks to our research institute at the Manchester University, we've got the funds to make this book open access electronically. So the whole book is open access. So it can be purchased, but it is open access and therefore free to use. And I think that's very much in the spirit of acknowledging that all those patients and storytellers gave of their time freely to us. That is the least that we can do. And the audio version produced by Elaine Clark is also completely free to access. So Jeremy's going to talk about the range of patient and care experience that we cover in the book, and also our experience of listening in this way, and finally implications for the NHS. Jeremy, over to you.
Thank you very much, Naomi, and thank you to Alastair and our panelists and everybody who's attending today. I also want to thank the 20 plus people who told their stories to us. Without whom we wouldn't have a book. It is really their book rather than ours. All we did was pull stuff together and put a little bit of commentary on it. It is their fate to be anonymous because they generously gave their time and their frankness on the conditions of anonymity, and so the names are pseudonyms, and therefore we're in a slight predicament in that we can't really thank them in the way that publicly in the way that we would like to, but their stories are the basis of the book and therefore incredibly important. Just to give you a flavour of the range of experiences and people that we talk to, and this is just a sample. So a woman who had a very difficult birth, the parents of a disabled young man who died in his 30s, a young man living with epilepsy, which he first contracted when he was very young, a mother and son both living with long-term and rare conditions, an immigrant to the UK from Africa who had a mental breakdown and then enduring mental health problems, a teenager with enduring mental health problems, the carer of a mother with dementia, the daughter of a man who died of cancer. This is very much birth to death and everything in between, and as much diversity of people and backgrounds and experiences that we could find. There are some limitations in the extent to which this is a representative sample, and we don't claim it is. And indeed, in the book, we discuss some of the difficulties of finding a truly diverse and representative range of storytellers. But it gives you a flavour of the breadth that we try to reflect. As Naomi says, we learned quite a bit about listening. I think Naomi is the person who's passionate about storytelling, but there's two sides to storytelling. There's the storyteller, but there's also the listener. And I think the experience of listening taught us quite a bit about some of the things that are needed in the NHS, but often missing. The irony is that I worked for a long time, and still do effectively, in the area of patient advocacy, and thought that I understood quite a lot about listening to patients. But in fact, I learned quite a bit in the process of doing interviews for this book. And it made me realise that I hadn't really got my head around listening. Some of the features of the listening we did: we had unlimited time, although it was interesting that most people felt they could tell a story in an hour, maybe an hour and a half at most, but there was no time constraint. We were able to give full attention without any distractions. We were recording the interviews. We didn't have to take notes. We didn't have to type into a computer. We didn't have an agenda. We weren't filtering people's experiences through our preset set of questions. We were just asking open-ended questions, trying to keep the conversation going, digging a bit further where people were saying interesting things that we wanted to know more. It was all about listening and keeping the conversation going. We didn't have an agenda. And then afterwards, we had a lot of time to reflect on what is the meaning of that account? What does it tell us about what's both good and bad? What are the implications for it? What questions does it raise? And indeed, some of the questions are asked in the book. We didn't have to take any immediate action. And of course, it's interesting that all of those conditions contrast with what typically happens when patients are listened to in a clinical and NHS context. Time is short. The people doing the listening are busy and often very distracted. We listen through the filter of our predetermined questions, whether that's taking a medical history or administering a survey. Think about the Friends of Family test. And people are typically listening in order to take action, making a diagnosis, trying to solve a problem, trying to deal with a complaint. It's very action oriented. So a lot of the conditions for really open and reflective listening are absent. And interestingly, there has been more recently a kind of a trend in listening to patient stories, boards listening to patient stories, where there is time to listen, but often people then don't reflect on what the account says and then move on. And one of the complaints about the use of patient stories is they become a kind of almost a kind of patient experience porn. You listen to the story and you think, oh wow, we've really connected with something really important and fundamental, and then you move on to the official business and any learning is lost. I don't think it's always like that, but it can be, and certainly a perennial complaint. So all of that leads us to ask some questions about, what are the implications of how can a busy, hard-pressed NHS really listen? One of the key principles for patient-centered care that we identify in the book is attentiveness. And I think the thing that I've been describing is creating the conditions for real attentiveness, real listening. And I think the challenge for the NHS, and I think it's a question that we might want to discuss in the Q&A here, is how, within the huge constraints the NHS has, can it create the conditions in which there can be genuine listening and genuine attentiveness to patients? Because without that, we will never nail patient-centered care.
Thank you, Jeremy. A very sudden stop.
Sorry, yes, that's me.
Catching up, I'm loving those headphones, by the way. You've accidentally muted yourself. Right, let's hear from the first one of our panelists. So we'll begin with Professor Kath Checkland, who is, as I said, Professor of Health Policy and Primary Care at the University of Manchester. Catherine, over to you.
Hi, thanks very much, Alastair, and congratulations on your award. I saw it yesterday and was very pleased. Yes, so I'm interestingly on the initial side. I don't know if some of you noticed, but I was down as Professor of Health Policy and Primary Care. My primary car is a Ford Escort, in case you're wondering.
To be fair, that is actually a cut and paste from the University of Manchester website.
Oh my God!
Yes,
Okay.
they seem to have they've missed off the E on your title on the website. So perhaps they know something you don't.
Exactly. And so I think to sort of start, I probably should declare, although I'm down as Professor of Health Policy and Primary Care, and I am that, I'm also a GP. And I think that I came at reading this book with my GP head on, really. And just to sort of let you know the history, I started my GP training in 1986. So for 35 years, I've been in and around primary care in the NHS. And I obviously the book is I recognise the book. I think it's fair to say that was one of the things that hit me as I was reading it. Of course, I recognise this stuff. But then I was thinking, well, okay, how does it chive? Sort of in my experience, what's changed and what's different, and how can we think about how we make things better going forward? And I think the book provides some real challenge for those of us in the front line of the NHS. But then I thought, well, actually, how does it fit with my own career trajectory and experience? And I think it's something you've maybe missed, and I'd be interested in the author's take on this, which is that when I did my GP training, patient-centeredness was everything. So you've got a little timeline at the beginning of sort of the 1970s and 1980s. So the 1980s was the beginning of my GP training. And honestly, I can say I spent 3 years being trained in patient-centeredness. I didn't learn any medicine at all. And actually the content was very limited. So, the clinical content, it was assumed we knew the clinical stuff. And we just spent 3 years learning to be patient-centered. And of course, that was it was at the early stages of the compulsory GP vocational training scheme. And of course it was Balint. So we were all Balint doctors. And I think that's something that you've maybe missed a little bit in your timeline, that certainly in general, and of course I'm speaking from a general practice perspective here now, not hospitals, that we all wanted to be Balint, or we all wanted a Balint view. And so we spent an awful lot of time. And actually what Jeremy said really chimed with me just there, is that he talked about the conditions for open and reflexive listening and saying that very often in short consultations they're absent. What we spent our GP training learning to do was to do it quickly. And I know that sounds a bit, that's a bit of an oxymoron, but that was the whole focus, is how can you do that? How can you be open and reflexive and really listen in a very short length of time? And we spent a huge amount of time trying to learn to do that, and to almost, as I say, probably a little bit too far, almost the exclusion of all else. And then of course I became a GP, and then I was a GP all through the 90s, and things did begin to change, and general practice training has changed massively. And so I find myself thinking, well, we obviously knew about patient-centeredness in 1985. We knew about it, we knew how important it was, and we knew how to do it to some extent. And yet here we are 35 years later and we're still not doing it. So I thought there's some really interesting questions opened up about that. And the one thing, I'll just highlight one thing which I think might be important. And again, I think the book made me think about it, but I didn't sort of see it in there to some extent, is about the rise of guidelines and what my dear lovely friend Steve Harrison called scientific bureaucratic medicine, which is the application of population level evidence to individuals via guidelines. And of course, there's lots and lots that we could say about that, but essentially what happened with QOF and with NICE guidance and everything else in the 1990s and into the 2000s was that we started having to run two agendas in our consultations. We went from my training, which was all about patient-centeredness, to having to run the agenda of QOF targets and fitting in with the guidelines. And very often, what's in the guidelines, it's population-based evidence, it doesn't fit with individuals. And so that real tension crept into general practice. And I think, I've not been deeply involved in GP training, but I think there was a moment, particularly in the early 2000s, where GP training lost a lot of its focus on patient-centeredness and became very focused on applying guidelines and teaching GPs to follow guidelines. I think GPs probably became a bit more risk averse. Because the more guidelines you've got, the more guidance you've got that NICE is telling you you've got to do this and you've got to do that, it becomes harder to focus on the patient. And it's about, and I think it was easier for GPs of my generation because we've been so steeped in patient-centeredness. But I think as those agendas came in over time, it became harder and harder. And then just the one final thing, which, you know, I don't want to take over Alastair gave us 5 minutes, I don't want to take over my time. Was the loss of generalism in hospitals. And you do mention that. And I think that was really, really important. Again, when I was training, we had generalists in hospital who would take a very open and holistic view of the patient. And then by the time, by the 2000s, we were basically, we had, as a GP, I had a choice of narrow specialists to refer to, and if it didn't fit with the narrow specialism, they bumped it onto their colleague, or they bumped it onto another colleague. And actually having that initial, if you've got somebody with really diffuse problems, and when I was reading some of the accounts, I thought, goodness, you know, some of these are really diffuse and difficult to tease out problems. What you need is a general physician. So those are my 2 points, really. Don't forget the importance of how guidelines and QOF in particular really came in and had a huge impact on general practice. And the other is generalism, and it's really important.
Thank you very much, Catherine. Right, let's now hear from Habib. Dr. Habib Naqvi is the director of the NHS Race and Health Observatory. Habib, over to you.
Thank you so much, Alastair, and thank you for inviting me to this forum. I'd like to begin also by congratulating HSJ, but also, as we're on this forum, particularly Naomi, Jeremy, and the wider team on the publication of this excellent book. Not just a book, but a vital resource to improve healthcare. And when I started reading it, I started reading it with my kind of professional hat on. But very soon after reading the first few pages, I went back 10 years to my experience of looking after my dad, who wasn't well because of diabetes and heart disease, became bedbound, had complications, was in and out of hospital on a very regular basis, and a very difficult time for all of us. And made me think about the lived experience of people and how it's very easy for policymakers and I guess ministers, etc., to devise policies, practices that will meet the needs of people without sometimes thinking about the needs of individuals within the kind of the wider group. And so it's important, you know, this resource, I believe, is critically important for us to think about, not just kind of high quality care for all, but, you know, high quality care for all, and that all being underlined and in bold. And whilst the NHS is not the only enabler to reducing some of these kind of disparities and these inequalities that play out, I guess, that we see in terms of disease outcomes and access issues, it does have an important role to play in ensuring that, you know, access is equitable and that experience is as optimal as it can be for different people. I often say that the NHS is perhaps the most visible expression of a shared social contract between people. But, you know, whilst it is exactly that, and we've seen that throughout the kind of vividly throughout the pandemic, we shouldn't be blind to some of its imperfections. And some of those imperfections include the kind of the stratification that we get in the way that care is delivered. it cannot be right that today in 2021, Black women are up to 5 times more likely to die during pregnancy, childbirth, or soon after. Asian mothers up to 2 times more likely. The sad fact that we had two very sad deaths of young Black men earlier this year who died as a result of unmet care with regards to their sickle cell disease. And the list kind of goes on. We also know that despite making less than 14% of the UK population, I'm specifically focusing on ethnic minorities here, given my role, that ethnic minority groups made up more than 1/3 of critical care admissions due to COVID. And of course, we need to look at the care that needs to be given with respect to individual needs as well. These are some of the symptoms that we have with regards to not just a specific disease that we can read about or learn about through the education system, but a disease that's probably within society as a whole, a disease of inequality. And it's critical, therefore, that this book and this resource is looked upon in order to design and deliver care to meet the diverse needs of our diverse communities. That reminds me actually of the topical issue at the moment, which is a backlog in elective care and appointments. A waiting list, as the Secretary of State announced yesterday, may rise up to 13 million people. But getting through that backlog should be as much about the quality of care that's given as it is about the speed of care. And this book made me think about exactly that. There may, going forward, may be a vision of getting through those appointments and that backlog as quickly as we can. But the risk there is that the quality of care drops off as a result of that. So this book is, for me, yet another reminder that we should be paying attention to those important factors as well. Finally, Alastair, before handing back to you, I'd just like to highlight the point that this is also a leadership issue as well. Taking action on this agenda has perhaps historically been something that some leaders have ignored at worst or paid lip service to at best. There needs to be a tighter focus on leadership, demonstrable leadership on this agenda, with accountability at the heart of that. And I hope that this book will enable us to further focus on this critical agenda going forward, particularly as we navigate ourselves through the pandemic and hopefully through the other side of the pandemic.
Thank you, Habib. Right, now our last panelist, Imelda Redmond. Imelda, you are still National Director of Health Watch, is that right? I know you're stepping down in the autumn, but you're still in post, yes? Imelda, are you there? Are you on mute? Oh, you don't appear to be on mute, but I can't hear you. Don't know if anyone else can. No, Imelda, we can't hear you. Oh dear. I don't know. I think the problem might be at your end rather than our end.
Sometimes leaving a meeting and coming back in can help with problems like that.
Yes, turn it back off and turn it back on again. Always the best advice. Well, let's just see if she pops up again.
The other thing worth checking out is whether you're still logged into another meeting. I've done that a few times.
I didn't know you could do that, log into 2 meetings at once.
Well, you can't, not properly.
So just while we wait for Imelda to hopefully return, if you have any questions you'd like to put forward, and please make them questions rather than statements, but it doesn't really work on on this kind of debate, virtual debate, please put them in the chat function, and I will try to ask as many of them as possible. Right, Imelda doesn't seem to be coming back right now, so I'm going to jump in and take the opportunity to ask a question of Jeremy and Naomi. My question is new technology, by that I mean information technology, is that the friend or foe of patient-centeredness?
Jeremy, shall I start?
Oh,
Yeah.
yeah.
Right. Oh, there's
Yeah.
Imelda, looks there. She's
Imelda.
back.
Yes, I'm here now, Alastair. Sorry, I don't know what, but leaving and coming back was absolutely the right thing. And I was saying, yes, I am still at Healthwatch at the moment, and it's the most exciting time. I wish I was starting, is what I think is the most exciting time for the organisation in its short history. So
Jeremy and Naomi, you've got advanced notice of my first question I'm going to ask after Imelda has spoken to us. So Imelda, take us away.
Well, I just wanted to say thank you to Naomi and Jeremy for this book. I having worked in the voluntary sector as an advocate in those sort of advocacy organisations, it's so close to my heart, because you can do all your research and you can have all your stats, but you need to do both head and heart if you want to bring about change. And I can think of examples from my background which really resonate with your book. So working with parents of disabled children, if you really listen to them, if you can really get their story out, and if you can play that back to the people who are the block, you can bring about some emotional change as well as process change. And I can think of examples, again, you know, my brain was just firing about lots of things that I've done in my working life. But I was Chief Executive of Carers UK for a long time, and we would never do anything without the carer story at the heart of it. And we brought about quite big change. What we wanted was for government to support local authorities to have emergency support in place right across the country. We did that by telling Linda's story, whose husband had had a stroke and was severely disabled, and her son fell off a balcony in Glasgow, miles away, and she couldn't leave her husband and she couldn't get to her son. And we had the stats to back it up, but it was Linda's story that changed the politicians' hearts to invest in that service. So I think it's incredibly powerful. I think I just was picking up as well a bit on Kath's point, which is about it's harder to focus on the patient. I would say that is absolutely true. People are in the mid 60s, you wouldn't have had a computer in front of you. You would have actually looked into people's eyes. But also, I think that's true across many professions within health and social care, because there are so many drivers that take you away from that listening and that intimacy so that you understand. One of the things that I've always been accused of, or we've been accused of in the organisations I've worked with, is that if we talk about people's stories, then it's anecdotal. It's not scientific. It doesn't, you know, but I think there's huge power in it. So for me, there are issues around, we know this is the right thing to do. Why is it not embedded? Why is it not happening? There's that great work, the health talk that came out of Oxford University, must be 2 decades ago now, really using people's voice to tell their stories. It's not catching on. What is it we need to do differently to embed the way of thinking, which is about real active listening? So for me, there are issues around learning from other places, and in the chat there was things about hospice, and I certainly in a previous role did some ethnographic work with people who were at the end of their life, the most powerful piece of work personally that I've ever been involved in, and people were happy to do that piece of work. So how do we learn from, you know, the hospice care, from palliative care professionals who are there to listen? How do we learn from volunteers whose role it is to sit beside somebody's bed whilst they're dying? How do we learn from what's already out there? How do we keep spreading it? And how do we make sure that we consistently get the authentic voice of the people that we're representing into everything we do? And I have to say, it's a challenge at Healthwatch that we're working really hard on at the moment. It's so easy to talk on behalf or say our stats show that 50% of people are really fed up with this, and and elective surgery this. But actually, what changes that heart and mind is, and this is Muriel, and this is and this is her story. Yeah, just to finish, I want to say thank you for doing this. Thank you for doing this seminar. And I certainly will take on to make sure that I disseminate this. So I'm really pleased it's free, because I will disseminate it through our network, and I think they'll really value it. Thank you.
Thank you, Imelda. Right, with a reminder about people are watching, adding questions to the chat function, I will return to the question that I asked in the small interregnum when Imelda was switching herself back off and on again. So Jeremy and Naomi, and I think Naomi was going to go first. Technology, is it the friend or foe of patient-centeredness?
So thanks, Alastair. We comment on this in our conclusion. So basically the book is bookended with, 2 discursive chapters, introduction and conclusion, and the rest are stories. And what we say is it could and should be a friend, but it's really important not to replicate some of the what Kath has quite nicely framed as kind of bureaucratic processes into kind of the new IT world. So to give some concrete examples, and it's incredibly topical, around access to GPs, replacing face-to-face consultations with remote Zoom or Teams consultation can be really helpful if those principles that we talk about are there, but in the absence of those principles, it will be a worse experience for patients. And listen to patients when they're saying that actually, the remote consultation won't work for them. I mean, that's notwithstanding for another day and another discussion, the state of primary care and general practice and the workforce shortages and the burnout and so on. So that would be my starter for 10, is that actually there's a huge opportunity, for example, to do away with, and COVID, of course, has done this at a stroke, fairly non-value adding follow-up outpatient appointments, Alastair, that we all used to go to, endlessly, where, they'd say, how you doing? You say fine, and that was it. That was it, off you went. Or
a lot of trusts now are doing patient-activated outpatient follow-up appointments.
That's great, and that exactly. So all those are just great, great examples. So can be a huge opportunity, but only when those principles are present, I would say. Jeremy.
Yeah, I think the example of remote consultations is a good one, because it can be friend or foe depending on how it's introduced. Remote consultations work for some people some of the time, but not everybody all of the time. And the key thing is, does the patient have a choice? Is the patient involved in decisions about how the service is going to be delivered, or are the decisions made by the professionals without any reference to the patient? So I think technology is good. It's an enabler. How it is introduced and used needs to be something that's done in a collaborative way, as indeed the care should be done in a collaborative way. So that would be my simple answer.
Kath, I'll come to you in a second, but just let me do a follow-up, if I may. There has been a lot of debate, HSJ has reported on, about the ability of to introduce these new remote consultation services, which did in the pandemic in primary care, total triage. And one of the functions was that people could email their GPs or their GP practice much more easily than they could before. In fact, they could do it for the very first time. And also GPs have been complaining about the overwhelm of people, of patients emailing them in the weekends and the evenings, basically outside office hours, such to the level now that the vendors have given GPs the ability to turn off the system when they don't want to receive messages. Now, I'll start with you, Jeremy, this time. do you think that is the ability of to email your general practitioner in that way? Is that something that is an important part of patient-centeredness, that ability to directly communicate with your clinician whenever you, the patient, wants? Or is it something that is going too far? I can't think of the right phrase. But it seems to me it's a very good live, because apparently happening in the States as well. So Bob Wachter did a tweet that clinicians' inboxes were filling up because of these new functions. So what do you think about that? Because in some ways you could see that who amongst us haven't wanted to email our clinician and get an answer that we think is particularly pressing? Jeremy, what do you think?
Like you, I have often been in a situation where I'd love to just email the practice, and the lack of functionality to do so is incredibly frustrating. So in an ideal world, it would be possible to do. One also has to take account of what are the most important priorities to fix. In the world of health inequalities and the picture that Habib was painting earlier, I think that's a nice to have. It may not be the most important thing to fix in the NHS right now in terms of delivering patient-centered care.
But I suppose the question is, do you think GPs should be able to turn it off at their own personal, that each individual GP can basically turn it on or off, depending on...
I'll give a final thought on this, and then I know that Kath was wanting to come in, but in an ideal world, the nature of the communication between the GP practice and the patient population will be a matter of discussion and negotiation between the practice and the local population. So there could be some discussion about what's going to work for this patient population with this practice. So it isn't a unilateral decision, but a discussion. So that's what I think about that. But I'm conscious that Kath wanted to come in earlier. So.
Yes, Kath, please.
Yes, well, clearly as a GP, I've thought about these things long and hard. Some of you may know I gave a lecture at the London School of Hygiene in May, and my point really was that was anti triage and anti remote by default, on the grounds that I think that and it's more of a philosophical point actually, that we need to, one of the things about when you think about access is about how problems are formulated. So the notion of telephone triage is predicated on the notion of discrete problems that can be formulated in a way on a form, or can be formulated in a telephone triage that we formulate the problem. Now most GPs would tell you that problems aren't like that, and sometimes the patient doesn't even know what the problem is. And so I guess my view would be, I guess I'm with Naomi and Jeremy on this to some extent, that it's got to be about choice. And the thing that worries me more than anything when I look at the debate that's going on in the media, about access, is that I think part of the issue is this notion of being able to choose face-to-face if you want to. We seem to have got ourselves into a situation as a profession where we're the ones who are saying, well, we'll talk to you and we'll decide if you need to be face-to-face. And I think we've got that wrong. I think that we need to, yes.
You in the Daily Mail.
Yeah, but I think we do need to have, God, don't tell me I agree with the Daily Mail, my goodness. But I think that what we do need to have is that, yes, obviously, that, I mean, we're overwhelmed. There is no two ways about it. We're overwhelmed. And I think that, and I think telephone access and online access can be brilliant for some people some of the time, but we've also got to keep that channel open whereby a patient can just wake up one morning, think, I'd like to go and talk to Kath, I'm going to make an appointment to see her, and they're just not tell anybody why they want to come and see me, but just make a face-to-face appointment. So I think that, to me, that's the bottom line. And then just on the email, Jeremy, yes, of course we've got to be able to turn it off. because I think one of the things, again, we lose it in this sort of notion of discrete problems, of healthcare as managing discrete problems. It's not like that. And these stories illustrate beautifully how it's not a matter of managing discrete problems. You've got a problem, you see it, you talk to a clinician about the problem, that problem's solved, you get another problem. And that's not what healthcare mostly is like. And I think we need to think about thresholds of help-seeking behaviour, I'm afraid. I think, you know, it's like building carriages on the motorway. The more carriages you build, the more cars there'll be. And I know that sounds, but you know, we do have a finite resource, and we can't just open the floodgates and expect the system to work. Thank
you very much, Kath. Right, I want to return now to a point that Sharon made, one of our viewers, who basically says, as we can see in the chat, is the lack of patient-centeredness, is it a systems problem, priorities, pathways, etc., or is it a practitioner problem rising from their training and professional cultures? And I think that's really, really interesting, because I think on one hand, it's quite easy to sort of blame the machine as if the individual actors within the machine didn't have any sort of choices to make. And of course, we know that's not the case, whether it be from a GP receptionist to a brain surgeon. Those people, to some degree, have a choice about how patient-centered they are, even within the constraints of a bureaucratic machine. I just should say for a moment, I'm a great fan of bureaucracy. People who've worked in countries without a working bureaucracy will know how chaotic life can be. But so in some ways, Jeremy and Naomi, and let's start with you, Naomi, I'm asking about the sort of classic sort of strategy versus culture challenge. How much is how much of the lack of patient-centeredness is down to the way the NHS is built, and how much is it down to the attitudes of the people who work within it?
So I've been bothered about this for a long time, Alastair, and the conventional phrase is that culture eats strategy for breakfast, you know, and that is
precisely what I was thinking.
That trumps. But actually, more recently, and in sectors not entirely just within healthcare, but other sectors as well, I've spotted that strategy can eat culture for breakfast. So that actually, if you keep pumping particular sort of instructions, if you like, endlessly pumping instructions. Kath's example is a great one around the quality and outcomes framework for general practice and guidelines. If you keep pumping that, then in the end, the culture that Kath described of patient-centered care practiced by the GPs in the 1980s and 90s, which I recall very well, actually, and all the Michael Bailent stuff as well around the flash of understanding and the concept, that gets drowned. That gets drowned. So actually, I think it's more complicated. I think strategy can eat culture for breakfast. But I'm also minded, and that's why we're really keen that we don't get into a kind of it's impossible to fix. I'm also minded that there are within, if you like, a slightly hostile environment and system. You're absolutely right. There are loads of individual professionals, practitioners, and also leaders, managers and leaders who demonstrate that actually we can listen to patients and we can offer patient-centered care. I got myself invited to an event run by the Care Quality Commission where outstanding GP practices just shared what they were doing. And it was just like a informal, like, you know, workshopy type thing. I was the only one who wasn't a GP or a professor of primary care or a practice manager. It was jaw-dropping what they were doing, these practices. It was a couple of years ago, just before the pandemic. Jaw-dropping what they were doing with patients with incredibly high needs, working with homeless people. You know, one practice, for example, I'll just give you one and then I'll be quiet, but one practice, for example, offered their homeless population to allow them to use their practice address as their place of residence, as where they lived, so that, because it would help with maximizing their benefit income. Because if you're no fixed abode, it's really hard forms of benefit income. Is that allowed? Is that allowed? And of course, those practices don't ask that. They went ahead and did it. They accepted Amazon deliveries from their homeless people. I mean, it was extraordinary. So it can happen, but you know, it is difficult in a tricky environment. So actually, I think there is hope, because there are a lot of people, and some of those stories actually demonstrated fantastic leadership. You know, there's a great story about a man dying from pancreatic cancer, and the role of the GP in that is absolutely brilliant. So it can happen, but we do need more organisations and a system that supports that climate of attentiveness that Jeremy's talking about. Otherwise, yeah, that's it.
I want to get Imelda's point of view on this, and then I'm keen to move on to the issue of inequalities, which is a very live one, and bring Habib into the discussion. A small aside about guidelines. I reckon if you trace most guidelines back through their production, through their dissemination by NHS England, through the working parties that various royal colleges might have put together, right before that, you'll find some activism by some patient group who felt particularly excluded and wanted their time in the sun, and insisted on some kind of basically insisted on some kind of rule that clinicians had to pay attention to their particular patient group. So I think it's really interesting, because in some ways that is patient-centeredness, that is patient activism producing, but it actually produces something which, as Kath has so eloquently explained, reduces the time to do attentive listening. And it's just to me an illustration of how complicated this debate is, and how that it's one of those classic things that any simple explanation is probably or solution is probably the wrong one. Imelda, give us your view on how much it is of the lack of patient-centeredness is down to do with the way the NHS runs, or the culture of the people within it.
Do you know, I think all I can say is I think it's both. That there isn't an NHS trust that doesn't have as its values all the things that you have put into your, you know, your building of what is patient-centeredness. They will have kindness, caring. They will have around competence. They will have around being a great place to work. So the intention is there. But then when people get into their roles, that skill that somebody talked about just a moment ago, I can't quite remember who it was, but that where you give yourself 100% to listen to someone when you're really, really busy, and they feel that they've got your attention, but you do it in a timely way. I think it was Kath's talking about her training. Now in life, you do that like if as a manager, as a leader, you sort of, you know, give people depth of hearings whilst they have a grievance, and you solve it quicker and you get things moved on. I do think though that the way all the guidance, if we put more value, human value, on all those systems and structures, and said, of all this stuff that we've got to comply with, which bits improve patient care and outcomes, and which bit just get in the way. And we say, in order for it to remain, it must have some value where it improves things. And if you can't demonstrate it improves things, can we get it out the way so that people can focus on what's really important? Because it's really, you know, it's really hard for people in those busy hospitals to slow down enough, or those busy G practices to slow down enough to really listen. But I think we waste their talent and their time a lot.
Thank you, Imelda. It reminds me of towards the end of Jeremy Hunt's time as Health Secretary. You might remember he used to have those famous Monday morning meetings where he'd get all the leaders of the health service in. And the one that was coincided with him becoming the longest term Health Secretary, I persuaded him, for me and a colleague, to come in and shadow him for the day through those meetings. One of those meetings was on removing regulations that did not contribute to patient care, and there was a various good and great Simon Stevens, etc., around the table all debating this. And you know, they dragged in some poor former chief executive and gave him the job of going off and doing a review of it. And as I went out of the room, I said, well, what you really should have done is got him to do a review on why all the huge number of reviews that had taken place beforehand hadn't worked. It seems to me that that is one of the NHS's biggest problems, is actually getting rid of things. It's very good at adding things, but very, very bad at getting rid of things. I wanted to turn to the issue of inequalities, which of course affects all things, but as Naomi and Jeremy, you talked about, is an element of a patient-centeredness debate. What do they say? The language, language of priority. I can't remember the exact quote, but something about language of priorities being particularly important to socialism, and I think you can apply that to the NHS as well. I think where we have seen advances in patient-centeredness in the NHS, it has been in those areas where people have been able to be effective advocates, either as individuals or as groups, whether it be early adopters around healthcare technology, or people able to influence what's happened to service change in their areas. And in that classic inverse care rule, often those people's health needs are not as great as other people who can't exercise such influence. Jeremy, Naomi, in whatever order, what does the book tell us about inequalities in patient-centeredness and how they might be addressed? And then Habib, I will come to you and ask for your responses. Jeremy, Naomi, whoever wants to go first. Jeremy, perhaps.
Yeah, I'm happy to go first. I mean, first of all, the book itself reflects some of the difficulties in addressing inequalities, in that probably there's a whole bunch of people that we should have talked to that we didn't reach, whose stories would have been just as important and compelling and different. But because of the inequalities that are structured into professional networks, we didn't get to all the people we should have done. So I think that, and it's a limitation that we acknowledge in the book itself, and it's an interesting debating point. So there are stories missing from our book, which in turn in itself reflects inequality in society. Within those stories, though, there were a number of examples of where inequalities played out in terms of racism, ageism, sexism, people making unwarranted assumptions about patients and carers. And I think that's a really important, it's one of the intersections between the general theme of inequality and the specifics of delivering healthcare. It is very easy, particularly when you're in default mode and you're busy, to make assumptions which are structured around prejudice and stereotypical ways of viewing groups. And some of that plays out in some of the stories that we heard. Some of the inequalities will be addressed through better listening, better attentiveness. But I think this is an area where, in particular, the domain of professional and organizational competence are really important. You need to take a system-wide view, I think, of what are the inequalities that already exist within our population that we are serving, and how best can we address those? How can we make manifest what is otherwise hidden or ignored, or that we make assumptions about? Who do we talk to in order, and who do we work with in order to address those inequalities in the design and delivery of our services? It seems to me that one of the implications of our book and the way we've structured our thoughts following from the stories is that there needs to be a system-wide approach to addressing inequalities in their diversity, thinking about ethnicity, class, disability, and a range of other both protected and unprotected characteristics. Of course, individual behaviours and attitudes and how we recruit and train staff are really, really important too. But I think we won't get our hands around inequality properly unless we think about it in a systemic way. So that would be, I'm probably going beyond the conclusions that we draw in the book itself, but I think those are some of the implications of the stories as I see it.
Naomi, anything to add before I
Yes,
continue?
I just want to point people to one of the stories in particular, which is, and we've used not their real names, but the story of Rabia is a really, really instructive one. I think it's an example of just listen to people's lived experiences. So Rabia is a Muslim Asian woman who looks after her mum, who has early onset dementia, and the challenges and barriers that she has faced, or she describes facing, and she's very angry, quite rightly so, very angry about what it's like for one Muslim Asian woman, newly married, with a career, actually, ironically, in the NHS, and how she cannot get care for her mother because of stereotypical views by various people in the NHS. Well, you're Asian, your families look after, your own kind. Terrible, terrible things. And she puts on her uniform or her badge so that she's taken more seriously because she's NHS staff. And it's those kinds of things. So I agree with Jeremy, it's about being systematic and systematic, but it's actually basically about being brave enough to ask somebody, what was the experience for you as somebody who is Asian or Muslim or disabled or gay? Tell us what that was like. And it's kind of, it requires courage and bravery on the part of healthcare professionals, but also leaders in NHS organisations. Roger Klein has published his report, which, today or yesterday, which is really clear about like 8 steps for organisations, NHS organisations to follow to get better at all of this. And I would say one of the steps has got to be attentiveness to lived experience of staff and patients who are likely to suffer some form of discrimination.
Thanks very much. Habib, what's your view?
There's a lot to talk about here, Alastair, so I'll be pretty brief. The NHS Constitution is very clear around dignity and respect and ensuring everyone counts. There is a need, I think, personally, to refresh the NHS Constitution, not just to refresh it, but to refresh the way it's socialized and looked upon and used as a lever to push forward some of the key themes that are being talked about on this forum. I think Naomi is absolutely right in terms of the health inequalities bit, and in fact, it's a bit like a golden thread, I would say, Alastair, in the sense that when you talk about digital care, as you did earlier on, I think about my 73-year-old mother who will not be able to switch on a computer or doesn't have access to a computer, let alone send an email to her GP. And of course, that brings into contention things such as, if you are on an email system, then where do you get the kind of the advocate or the person with you, sharing information and all the ethical and moral issues that come there. So we need to look at interventions and policies that help to reduce health inequalities, avoiding the risks of making them wider. But there are assumptions, there are biases, and we know of those. There are subtle cultural differences in the way that some people, some communities present their symptoms. I did some research 20 years ago looking at chest pain, and I know in the South Asian community that there are subtle cultural differences. How those differences come across electronically or through an email, I'm not sure how that's going to effectively work. But there are also biases in terms of doctors' assumptions around pain management, which we are kind of all should be familiar with, looking at conditions such as endometriosis, for example, but also biases within policies and processes that exist within the NHS themselves that need to be overhauled in order for us to focus on what we really do need to focus upon. And then thirdly, biases in the evidence upon which interventions are designed and rolled out. And I think to some work that we published at the NHS Race and Health Observatory on racial bias and false oximetry just a couple of months ago. You may have seen it on the media over the summer, in the sense that actually these devices were designed on the back of research that was carried out predominantly on white populations. And so when you have more melanin in your skin, the readings from pulse oximeters may not be as accurate as they are on white skin. And so therefore, we need to look at interventions that are fit for purpose to meet the diverse needs of our diverse communities. And that goes back to the previous point as well, if I can just join up the dots, Alastair, is around research and education as well. Diversifying education, undergrad, medical, nursing, allied health professional education within universities and colleges will be absolutely essential for this. The number of clinicians that contacted me or the NHS Race and Health Observatory following our review on pulse oximetry, who said that actually we weren't taught about this when we were at university. We weren't taught about different skin conditions. That is absolutely critical. So yes, this is a issue to do with policies and processes, and Naomi's point around the report that was produced yesterday by Roger Klein is absolutely right. But also, this is about culture as well, because it's not just about getting people to do something because they have to do it as a result of regulation or as a result of contract, but getting people to do that because they want to do it. And that's where culture comes into play. I personally see that as two sides of the same coin.
What, Habib, do you think about my point that often when it comes to the whole patient-centeredness debate, it is, this is white middle-class people with all the privileges that they, I should say we, in my case, have, tend to dominate this space and can, I would imagine, effectively crowd out the wishes and concerns, etc., of people who have less ability, not less ability, but less opportunity to advocate. Is there a need for the NHS to sort of, I don't know, make allowance for that? In other words, to make especially, to try especially hard to listen to those sometimes excluded communities, and also to say to the perhaps over-enthusiastic, white middle class advocacy-dominated groups, you just got to wait your turn.
Yeah, you're absolutely. I mean, there's two parts to that, Alastair. Firstly, in terms of engagement, it needs to be both sustained and meaningful, and it needs to be without a level of hierarchy in it. So all voices need to be around the table. And in fact, we shouldn't be expecting people to come to the table, but we should be going to them. And that's the kind of the critical point here as well. I know in the work that I do that without meaningful, real engagement, I will not be able to put forward the evidence base, the insight, and the recommendations that will have impact on people's lives. So that's kind of one aspect. But there's another aspect to that as well, which is around representation, which is around representation in leadership within the NHS itself. If we're in the business of reducing health inequalities, which we are, then we need a workforce and leadership which is representative of those communities as well, and that's absolutely essential. And that link is absolutely essential.
So Habib, obviously that's an issue that's very of interest to me, but I'm keen to keep these on patient-centeredness. Let me just ask you another question in relation to patient-centeredness. I could imagine some groups who are advocating for South Asian people in Birmingham or Afro-Caribbean people in South London saying, you don't need to listen to us. You don't need to listen to us particularly more to hear what our problems are. You know what the problems are. You know that, these services, the sickle cell services are underfunded, or that services for diabetes prevention need to be much greater in Slough and in parts of of Birmingham because of the higher incidence in the populations there. In a way, this big debate about patient-centeredness and listening to it is a way of sort of basically, you know, delaying that action. And actually, in a lot of cases, everybody knows what needs to be done. They should just get on and do that. What do you think about that?
I mean, the first thing to say is that actually your point around the connectivity between workforce and patients is important. I think we need to look at that as well, and that cannot be ignored. But your second point is right as well. I mean, the question is, do we really know what to focus on? And what I mean by that is, are we really looking at the causes of the causes here? Or are we looking at some surface level issues where we can have quick action, but will it really lead to meaningful change?
Wouldn't a lot of people in those communities say, well, we don't care if it's quick surface action, please don't shut down our clinic? You know, do you see what I mean? I'm just wondering this bit. Not more debate, please. Not more like trying to get to the causes of causes.
Yeah, but Alastair, you need to focus on the right things. I mean, we need to focus on the things that will have a positive impact. And without that level of evidence and that insight, you know, we could be going down the wrong road and inadvertently increasing inequalities rather than closing them down. And so the evidence base is absolutely critical as part of that. That's not to say that we should be spending 2 years, 3 years, 4 years on evidence just for the sake of kind of research for the sake of research, but looking at action-based research and co-producing that with the people from the communities and the patients themselves.
I know, Habib, that the work that the observatory doing is doing right that, and that you're working on some very interesting stuff around maternity and other things that will begin to surface that. And I think that will be very significant. Jeremy and Naomi, you both had your hands up. Jeremy first, please.
I was going to continue the debate about listening and whether we don't need to if you already know the answer. But actually, there's a more interesting question from Kieran, and hi Kieran, by the way, about which is relevant to this. I just wonder if you could take that, Alastair, and maybe.
Okay, I'll just see what Naomi wants to talk about, and then I will absolutely do it.
Yeah, I just don't think it's either or, Alastair, and I absolutely detect your justifiable impatience that kind of where we know what the problem is and we know what the solution should be, then go for it rather than just asking all over again. And I do know that people in very deprived populations say, actually, just, you know, we've told you a few times we want that health centre, just go and get, don't ask us again. But I don't think it's either or, because I think what our patient stories reveal is kind of like a granularity, a kind of experiences that actually managers and leaders are not aware of. They are not aware of in the case of, you know, people from ethnic minority backgrounds, the microaggressions that are experienced by patients. So I think it's both. I don't actually think we haven't surfaced the extent of, if you like, disadvantage and discrimination that does take place at an individual level. Actually, it's also about people with rare conditions, patients with rare conditions. We've also found that. So I think it's both. I completely get where there's an inverse care law that needs to be addressed. Like now, we've known for ages there are fewer GPs per head of population, fewer district nurses in poorer communities. ICSs need to fix that. So, but in addition, they also need to listen to those individual experiences. Over to Kieran.
Yeah, so Kieran asked a vague question, which is, there are some communities who are culturally less vocal. That's obviously true. I would add that there are certain patients who are just less vocal. And I suppose it comes back to this sort of, you know, the people who shout the loudest get the most attention. Jeremy, Naomi, talk to us a little bit about the way that you get to hear from those patients or patient groups or communities that don't come forward with their experiences, don't, you know, agitate and advocate, because obviously often those people are the ones bearing the greatest health and care burdens. How do you go looking for those for those people?
I think Kieran's question could be applied to the level of the individual patient or to communities. And it depends whether you're talking about people being engaged in their own care or a more general conversation about services at a population level. So in terms of the, I guess it's a different set of questions for each, but to the extent that it's about engaging with communities, I mean, I think I, to some extent, would defer to Habib's expertise in this area, but I think a lot of it, I think, can be about finding ways of connecting with the communities through intermediate organizations like community groups, faith leaders, the voluntary sector groups. So that are organizations and voluntary groups who are out there to provide a linkage between services and particular communities. So there's something about making the most of that. I think there's something very interesting in Kieran's question around people need to know they have permission to challenge and question and ask for the things that they want. And not everybody knows they have permission. Some people are kind of, the culture they're used to is that they get what they're given. And it's really difficult to overcome that. And I think that they're in the realms of the kind of principles behind shared decision making. That and the lead probably has to come from the clinician to say, no, it's not for me to make the decisions. I can't make them alone unless I understand more about you as a person, and we have a conversation together about what's going to work for you. One of the barriers to shared decision making is, for some people, is the understanding that they have the right to share decisions. So it isn't just about, as Kieran rightly said, it's not just about some people being more vocal and sharp-elbowed than others. It's you need to have the sense of entitlement in the first place, very often, to be able to make the first steps in asserting your needs.
And Jeremy, just let me ask you a bit of a question. You and I have debated this for God knows how many years. Do you think people not only have the right, but they also have a duty to do it? That a responsibility, and in a, the NHS is a shared endeavour, which is jointly funded by all. I mean, actually, if people go in with an expectation that they've got to share information, that is more. I just wonder if there's a culture shift. We all know that those people who take an active involvement in their healthcare get better outcomes, and there are reasons why people tend to do it and things like that. But is there some kind of messaging around the need to do that, not only for yourself, but because the NHS works better if people do, that goes along with requiring the system and the individual clinician to also engage more directly?
So I think it's a good thing for the NHS to try and think about how to create the conditions in which people can feel more at home in asserting their needs. I'm not sure, I can't imagine, knowing that NHS messaging is often quite clunky and sometimes contradictory, I'm not sure you'd do it through an NHS messaging campaign. I think I'd be more inclined to think about whether there are other ways you can get those messages across.
Absolutely. Absolutely. I'm mindful of time. We've got 7 minutes left. Kath, we haven't heard from you for a while. Perhaps you might give us a few reflections on the debates you've heard. What do you imagine? I know there's no such thing as your average GP, but let's imagine for one moment that there is. What do you think that they would have made of this conversation? How relevant to their lives do you think it would have felt?
I think very relevant, and I think I thought you were going to ask me then, how would GPs respond to the stories? Because to me that was, as I was reading them, that it was really interesting, because I found myself, I had a yes but head on quite a lot of the time, and actually, but I wouldn't have done it like that. But I wouldn't have done it like that. But if they'd come to me. If I'd been the one, if they'd spoken to me, I would have done that differently. Now, of course, and actually that's probably not, I mean, in an ideal world, hopefully I would in different places. But I think that for me, I think it is about that. I guess it's, to some extent, it's about having compassion for the providers at the same time. That sometimes, I mean, I know that, I used to have this conversation with my colleagues quite often. I'm an awful lot better at the beginning of a day with a cup of coffee inside me than I am at the end of the day, seeing the umpteenth patient of the day. And so those things, you know, how we respond, and I guess one of the things is to just incrementally shift. I think, you know, we can't possibly be 100% patient-centered all the time. We can't possibly be 100% attentive, frankly, all the time. Because it's too exhausting. We wouldn't have any GPs left. But I think what we can do is incrementally shift. And if we incrementally shift everything by a little bit, then actually that's how we start to make a difference. And I think that's where the training comes in, because of that sense that you can, if you can inculcate people with the notion that this stuff really matters, and you know, books like this would be really helpful for that. You know, dish it out to the GP trainees, because that, and actually the fact that it's free, I can put Naomi in charge of in contact with the GP trainee program in Manchester. You know, that may well be a really useful resource for people in training. I mean, in terms of that, I mean, absolutely. I guess I don't have a huge amount to say in terms of the kind of debates around, you know, ethnicity and the microaggressions that are experienced by patients, because I agree with Naomi. I think that these, as a privileged white middle class person, sometimes these things are invisible to me, and that's shaming, really. And I think that knowing that's the case and having it brought to our attention is terribly, terribly important, both as sort of institutionally and individually. So I think that's one of the things. I think GP practices don't have much time for reflection as a group. We do a lot of reflecting as individuals. We don't have much time to reflect as a group. And I think that's something where these kind of debates can more usefully be addressed, particularly around our patients from marginalised communities, our underserved populations, because frankly, we're the one, you know, I think underserved is a brilliant language to use, because we're the ones underserving them. You know, and that it kind of points to our responsibility, and so I think that's one of the things I think we need to address, certainly at practice level.
Thank you, Imelda. Very briefly, if you will, for which my apologies. Your last words.
Well, I found it really interesting. We started with stories and we've ended up talking really about how we need to engage with people from all communities in an ongoing type of way. It needs to be a cultural thing, storytelling being one of those elements, but there are lots of other tools that we'll need to bring in. And I'm just reflecting on the role of Healthwatch at a very local level. Their role is to go into communities, to build those long-term relationships, so that when you need to know something, you have an established relationship already. And so that if I give an example of in the Midlands, an area that had lots of Somali people who were not using GP services, who were not registered. So you know that, and then you spend a bit of time sorting that and working out why it is, and then you can, you know, so you need to go back. Vaccinations, you've got the established relationship. So I think it's been really interesting moving from stories to engagement and thinking about all the different tools that you need to have in your toolbox to really listen and do things that are in the interests of everybody. Thank you very much, Imelda. Right, ladies and gentlemen, we are out of time, I'm afraid. We've approaching 2 o'clock. Can I thank Kath, Imelda and Habib for being such interesting panelists, and obviously for Jeremy and Naomi for writing this book and telling these stories. I will make one prediction, which is this debate ain't going away, and I could well imagine whoever's editor of HSJ in 20 years' time still having it to some degree. And I think what we probably haven't done, which we probably should have done a bit more, is to talk a bit about the reflector, is to talk a bit about the way in which patient-centeredness in some areas has significantly increased. And I can think of a number of services across the NHS which are much, much more patient-centered
than they were 20 years ago. And I think, you know, it's a natural thing that you look at things aren't working to try and to fix it. But there is, you know, there has definitely been some progress, and people like Jeremy and Naomi have been instrumental in it. That's all for me. It's been a pleasure to chair. I'm off to walk from the source of the Thames to Oxford. I hope you all have a good weekend.
Oh, thank you.
Bye-bye.
Thank you all
Bye.
very much.